We have just started the recording of this CAC meeting in compliance with CMS. For the record, prior to doing so, I announced that we would make an audio recording of the CAC meeting and consented on behalf of all participating MACs. So once again, good afternoon, everyone, and thank you for joining us today for the Multi-Jurisdictional Peripheral Nerve Blocks Contractor Advisory Committee meeting. I'm Dr. Olatokunbo Awadeli, one of the Contractor Medical Directors at National Government Services. The participating MACs for today's CAC are Palmetto GBA, CGS Administrators, National Government Services, and Noridian Healthcare Solutions. I am co-moderating this CAC with several Contractor Medical Directors. Dr. Moynihan, can you introduce yourself, please?
Yes, hi, Eileen Moynihan from Noridian Healthcare Solutions, and my background is as a rheumatologist. Thank you.
Thank you. Dr. Durden, can you please introduce yourself?
Certainly. This is Mark Durden. I'm a physical medicine rehabilitation physician, and I am a medical director at National Government Services.
Thank you. Dr. Volker, can you please introduce yourself?
Hi, my name is Dr. Judith Volker. I'm an OB/GYN, and I am a Chief Medical Officer at Palmetto GBA.
Thank you. Dr. Hopkins, can you please introduce yourself?
Hi, this is Mike Hopkins. I'm a medical director from Palmetto GBA, and my background is in emergency medicine.
And last but certainly not least, Dr. Lovelace, can you please introduce yourself?
Yes, I'm Dr. Meredith Lovelace, and I'm also an OB/GYN and medical director with CGS Administrators.
As MACs, we would like to extend a special thank you to Palmetto GBA and Melissa J. Robinson for all her work in hosting this meeting and ensuring everything runs smoothly. Now, the purpose of today's meeting is outlined in the CMS Program Integrity Manual 100-A, Chapter 13, Section 2.4.3. This committee is designed to provide a formal mechanism for healthcare professionals to be informed about the evidence used in developing the LCD and to promote communications between MACs and the healthcare community. Our panel consists of subject matter experts from various fields of medicine who will discuss the quality of evidence in the medical literature regarding peripheral nerve blocks. This discussion may potentially lead to the development of a peripheral nerve block LCD. The CAC members serve in an advisory capacity as representatives of their constituency to review the quality of the evidence used in the development of an LCD. Since the CAC is advisory in nature, the final decision for all issues resides with the MACs. Accordingly, the advice rendered by the CAC is most useful when it results from a process of full scientific inquiry and thoughtful discussion in this public forum. Subject matter experts, please introduce yourselves by briefly stating your name, profession, affiliation, and any conflicts of interest, if any. We recognize that each SME has submitted a written conflict of interest form, but please verbally present any conflicts or disclosures that may be relevant to our audience. Our SMEs include Dr. Benjamin Northrop. Could you please introduce yourself?
Hi, yes, I'm Ben Northrop from Washington University, St. Louis, Missouri. I am a radiologist and no conflicts.
Thank you, sir. Dr. Alexander Bautista.
Hi, I'm Dr. Alexander from University of Louisville. I'm a pain management anesthesiologist. No conflict of interest.
Thank you. Dr. Deepak Azad.
I'm an internist in occupational medicine. That's my work of expertise, and I have no conflict.
Thank you. Dr. Marzina Buzanowska.
I am a PMNR pain management physician, and I have no conflicts of interest.
Thank you. Dr. Laxmaya Manchikanti.
Thank you. Thank you. I'm Lakshmaya Manchikanti. I'm the chairman of the board of American Society of Interventional Pain Physicians. I'm an interventional pain physician. I also serve on the Career Advisory Committee for CGS, Kentucky. I also have affiliations with University of Louisville and University of Louisiana, in Shreveport.
Any conflicts, sir?
No,
to
I have
disclose?
no.
Okay, thank you. Dr. Michelle Poliak-Tunis.
Hi, I'm Michelle Poliak-Tunis. I am a PM&R pain physician at the University of Wisconsin-Madison, and I have no conflicts.
Thank you. Dr. Brian Paquette.
Yes, my name is Dr. Brian Paquette. I'm a neurologist and interventional pain physician located in Indianapolis, Indiana. No conflicts of interest.
Thank you, sir. Dr. Stephen Barrett.
Yes, Stephen Barrett. I'm a podiatric surgeon and also the chairman of the Board of Trustees for the Association of Extremity Nerve Surgeons. I have no conflicts of interest.
Thank you. Dr. Erin Nelson.
I'm Dr. Erin Nelson, practice in Ames, Iowa. I have no conflicts of interest.
Thank you. Dr. Ann Mosconi.
Hi, I'm Ann Mosconi. I'm an occupational therapist and a certified hand therapist, and I'm representing the American Occupational Therapy Association, and I'm pleased to be here today, and I have no conflicts to report.
Thank you. Miss Mary Walsh-Sterup.
Yes, I'm Mary Walsh-Sterup. I'm also an occupational therapist, certified hand therapist with the American Occupational Therapy Association, and I currently practice in mid-state Nebraska.
Thank you. Dr. Michael Schneider. Dr. Michael Schneider. Dr. Kevin Vorenkamp. Melissa, can we please make sure that check whether they are on the call and volume stuff? Okay. So while we're doing that, prior to this meeting, the MACs conducted a multi-jurisdictional work group to discuss pre-decisional concepts and the medical literature, preparing a list of topics and questions for the experts to address. This allows them to supplement their presentations with their own medical literature reviews. Today's meeting will run from 2 to 4 p.m. Eastern Time, and it will be recorded, as I stated earlier, and placed on each respective MAC's website. As we conduct this session via teleconference and webinar, please focus on the strength of the medical evidence rather than personal experience. Should the medical evidence be silent or inconclusive on a topic, we encourage our SMEs to highlight these areas found in the literature. Please adhere to the time limits for each agenda topic to ensure a smooth dialogue. When you begin speaking, state your name so we can accurately capture contributions from all participants. To maintain order, we want our experts to speak uninterrupted. If there are questions from MAC medical directors after your presentation, please use the raised hand icon to indicate your question, and the moderators will acknowledge you prior to speaking. Likewise, if a SME has additional comments or concerns, please raise your hand for acknowledgement. Ms. Robinson may also recognize and facilitate raised hand icons to allow you to be acknowledged. All speakers are asked to mute themselves when not speaking to minimize background noise or feedback. We will encourage a meeting of civility when addressing an issue. Please focus on the topic rather than the individual or practice behind an opinion. The moderators reserve the privilege to ensure a smooth meeting. Additional comments or questions should be submitted in writing, as time constraints may limit in-meeting discussion. Thank you again for your participation and dedication. Let's have a productive and insightful discussion. I'll now hand over to Dr. Moynihan, the questioner for the first section. Dr. Moynihan.
Hi, could I know whether two of the speakers are on the call, Dr. Schneider and Dr. Norenkamp? So let me ask any of the others if they can answer the first question, which is, what is the evidence and or societal guidelines concerning the provision of non-surgical conservative care prior to proceeding with therapeutic genicular nerve blocks or related procedures like radiofrequency ablation or cryoneurolysis? Would anyone answer since the speaker is not on?
This is Dr. Manchikante. If you want me to, I would.
I'll take any answers at this point on what the evidence on conservative therapy or what the societal guidelines are. If no one knows for sure, I can put it at the end to see if Dr. Schneider comes in. I realize you weren't assigned this question, but if someone can answer, that would be great.
I think we have a volunteer. I'm not sure if you heard, Eileen. One of our SMEs was volunteering.
Dr. Manchikante.
Yes.
So there is no specific evidence or societal guidelines for the non-surgical or conservative care prior to proceeding therapeutic genicular nerve block or related procedure. However, as we go with all the conservative measures, non-steroidal anti-inflammatory agents, exercise program, physical therapy, all of these should be considered for certain period of time, 3 months or so. And after that, we should consider a genicular nerve block. And if we are successful with the genicular nerve block, we can consider radiofrequency ablation.
Thank you, Dr.
So this is Doug Beal. If I could add to, so agreed with Dr. Manchicanti. If I could add to that, there's 2 level 1 trials. One compares, it's by Davis et al., comparing genicular nerve RF versus steroid injection. The other one is by Chen, EN, comparing radiofrequency ablation to Visigo supplementation. So there's 2 level 1 trials on this.
All right, thank you, Dr. Bale. Dr. Azad, is there any evidence to support a minimum trial duration and number of therapies of conservative care before proceeding with genicular nerve block?
There should be 6 weeks of trial conservative management, just like what we do for facet joint injections or other types of treatments. That should be with the non-steroidal anti-inflammatory agents and any other drugs, plus physical therapy and structured exercise program.
Well, you mentioned that you could try certain medications or structured program, physical therapy. So I'm wondering, are you suggesting that they be in serially or in conjunction with each other, provided there's no problem with the taking of medication, any of the medications?
I don't think there should be a problem, and it can be provided in conjunction with each other. So.
Thank you. Dr. Poliak-Tunis, could you share insights into the absolute and relative contraindications for receiving a genicular nerve block, particularly informed by studies like McCormick in 2018 or any others that you have found?
Sure. So based on this McCormick study in 2018, the contraindications for genicular nerve block included active infections, bleeding disorders, current anticoagulation or antiplatelet medication use. For this study specifically, allergy to medication used in their protocol, as well as pregnancy and pacemaker. Again, this was based on this study.
Thank you. Dr. Northrup, what does the evidence indicate regarding the efficacy and safety of various genicular block techniques, such as using anatomical landmarks versus fluoroscopic or ultrasound-guided methods?
Yes, thank you. So this is really a couple questions rolled into one. The first being landmarks versus imaging guidance, and then the difference between those two. So to answer the first portion of those, just simply using anatomic landmarks is quite rare now, and most of the studies just don't have much information on that, mainly because at this point, if you were to create a trial, it would be unethical to use a control arm, so to speak, with only anatomic landmarks. So essentially everything is fluoro versus ultrasound. What we do see in the evidence when they've surveyed providers is that essentially nobody does it without imaging guidance of some type. A 2024 study, very recent, showed that approximately 85% used fluoroscopic guidance, 7.2% used ultrasound, and a little under 7% used the hybrid method, ultrasound plus fluoroscopic guidance. 0 used anatomic landmarks. So very little evidence for that out there. And certainly when you look at how the procedure is done, and how these landmarks were created for imaging guidance, you couldn't do it very well without imaging guidance. So it's really something that isn't an issue. Of note, since we are talking about coverage, there is no difference in payment. So whether we're talking about the block or the ablation, code 64454 and 64624 both say including imaging guidance when performed. So whether or not imaging guidance is performed, you code it the same way, and it will make no difference in, and certainly how one would code it or how it would be reimbursed. Now, to your next question concerning fluoro versus ultrasound, this is where it gets a little bit more complicated. So there is one study, non-US, that compares fluoro and ultrasound guidance from Kim et al. I can send you the citation if you'd like in the comments, and that showed that the outcomes were not significantly different. There is another smaller study from Turkey that shows a slightly greater pain reduction with ultrasound guidance, but it was a much smaller study. And then the next topic here so that was in terms of the efficacy of it. In terms of safety, so all the major studies have shown very similar safety profiles between fluoro and ultrasound. However, there is no question that you can, with ultrasound, better localize things like the pes anserinus tendon, the joint capsule adjacent vessels, etc. And you could, in theory, reduce the risk of these rare but reported complications, such as pes anserinus bursitis or pes anserinus tendinitis, tendon injury bursitis, periarticular hematoma, septic arthritis, etc. These are, of course, very, very, very rare and not likely with either method. But in theory, the ultrasound guidance could potentially reduce those risks.
Well, thank you very much. Dr. Manchikani, what factors might influence genicular nerve block outcomes considering variables like the number of needles, nerves blocked, needle size, etc.? Additionally, could you address the lack of direct comparisons?
There are no comparative studies. There are no society guidelines. Generally, these are performed on three nerves, superomedial, superolateral, and inferomedial. Some have used other nerves like medial retinacular, infrapatellar, but that it is not a common practice. The CPT code insists on or involves three genicular nerves. So those are the three nerves should be done. If it is not done, then it is not considered a genicular nerve. It will go into a peripheral nerve block. In reference to number of needles for nerve blocks, there are no studies at all looking at different number of needles. But for radiofrequency neurotomy, there is a study which is used 3 needles versus 1 needle per nerve. That may make some sense because it can produce a larger, longer type of lesion. But for genicular nerve block, there is no need for any more needles, and there are no studies at all. The nerves blocked, I just described that. Sizes of the needles, it really doesn't matter. Some use 22 gauge, some use 25 gauge. I prefer personally 22 gauge. Most of the studies use 22 gauge needles. And KL grading, all the studies used grade 2 or higher. As you know, grade 0 means no pathological features. Grade 1 is doubtful narrowing of joint space and possible osteophytic lipping. Grade 2 is definite osteophytes and possible narrowing of joint space. Then grade 3, moderate multiple osteophytes. Grade 4 is large osteophytes, marked narrowing of joint space with severe sclerosis and definite deformity of bone ends. So based on the literature, they are recommending these to be performed in patients over grade 2 or higher, not grade 0 or not grade 1. And since there is not a direct comparison between these techniques in the literature, it is not hard to answer the question, but it may not make any difference at all how many needles you use and 3 nerves you block, because that is what the CPT code says. Size of the needles does not matter. KL grading is important because if we are using genicular nerve blocks other than osteoarthritis, then it is important we have to remove the restriction on KL grading and just go with the chronic pain, which is disabling or severe enough to be affecting their ability to function.
Thanks very much for that answer. Dr. Batista, what is the current evidence surrounding the efficacy of genicular nerve blocks compared to placebo or sham procedures?
Literature out there. However, individual studies have shown like mixed result. It's limited to time frame of like evaluation. Some of them are just like 12 weeks, and some of them have different like ranges of like osteoarthritis. However, there is a recent publication, January 2025, published in the Journal of Pain Research, where they did a meta-analysis of 13 randomized controlled trials with 7, and they have found out that genicular nerve blocks was found to be superior to other analgesic regimen. But currently, there's no societal guidelines, and again, with a lot of mixed results from individual studies, but those studies are limited because of the randomization may not be that accurate, and some of them may not be reproducible. But overall, in this meta-analysis, it's shown that genicular nerve block is superior to any analgesic regimen for knee pain.
Thank you very much. Dr. Buzanowska, could you explain any guidelines or evidence related to the frequency of therapeutic genicular nerve blocks and whether repetition of these injections is advised?
Hello, yes, this is Dr. Martina Buzanowska. And so I was a little bit confused about this question because therapeutic blocks, in my understanding, those are blocks where you inject a local anesthetic combined with a steroid, so some sort of therapeutic agent. And there are no society guidelines or studies that look at the efficacy of therapeutic genicular nerve blocks. The studies looking at genicular nerve blocks are ones where the nerve blocks are used as diagnostic tool to see and predict the outcomes of radiofrequency ablation. So I am not aware of any studies that or societal guidelines that look at therapeutic blocks that include steroids. I welcome other people's input.
Thank you very much. Is Dr. Bornkamp able to be on at this point? Or still having trouble?
I think I'm in the general audience, but I am listening.
I hear you. I hear you. So could I ask you to respond to what does the evidence say about diagnostic genicular nerve blocks prior to radiofrequency ablation procedures, referencing works like McCormick in 2017 and Jameson in 2018? Are there particular criteria for selection?
Yeah, I think it's a bit limited. The original McCormick study, he showed very comparable findings, whether you proceeded directly to radiofrequency ablation or did the diagnostic block. And in the original, with his original study, he was looking at, I think, 50% relief and 1 ml volume. He did a subsequent study a couple years ago when he looked at being more restrictive, using only 0.5 milliliter at each location. And actually, even if he graded to, I think they looked back at their study, and even if he used 80% or 90% as a selection criteria, it didn't make much difference in terms of outcomes with RFA. So kind of the general sense is that the genicular nerve blocks have very limited utility in predicting response, limited prognostic value, but they still may be indicated for specific patients, but do not necessarily increase the success of radiofrequency ablation.
All right, thank you. We're going to move on to radiofrequency ablation. And I can't see who's on. Is Dr. Schneider still not on? Could someone answer?
I sent him an email and resent him the link.
Okay. Maybe I'll leave that question till after the others are asked. And then we'll come back and see if he was able to get on. So I'm going to move to Dr. Poliak-Tunis. How do different genicular RFA techniques compare in terms of safety and efficacy, such as conventional RFA versus cooled RFA and anatomical landmark versus guided procedures?
Sure. So with regards to efficacy and safety and with different genicular radiofrequency techniques, based on a study published in 2022, the Capital study, it noticed that cooled radiofrequency provided better short-term improvement in VAS scores rather than traditional radiofrequency, with a time interval of pain relief of greater than 50% pain decrease, an average of only 2.6 months for the traditional radiofrequency group, whereas it was 11.1 months for the cooled radiofrequency ablation group. And the study also noted that long-term positive outcomes greater than 6 months really depended on the size of the lesion. And this is why cooled radiofrequency, as well as larger traditional radiofrequency ablated treated patients, received longer time intervals of pain relief, which is likely due to larger volume of denervation area that's captured greater number of articular branches. And by creating a larger angle independent lesion, the likelihood of ablating the target nerves increased, which could explain the success of cooled radiofrequency when compared to traditional radiofrequency. Now, with regards whether ultrasound versus fluoro-guided radiofrequency ablation techniques, and again, this is now based on a study published in 2021 that you mentioned there. Fluoroscopy guidance can easily identify nerve targets as they run adjacent to the periosteum and offer better needle visualization regardless of tissue depth and needle gauge. Whereas in contrast, ultrasound guidance offers the benefit of in-office based, usually cheaper alternatives with no radiation exposure and improved safety due to better visualization of adjacent soft tissue structures. However, it is the authors did state, and the literature does support, that the choice of technique should be based on the availability of the setup, as well as the individual experience and comfort with imaging modalities.
Thank you. Dr. Manchikani, it's not going to be finally, but could you provide insights into the frequency of genicular RFA procedures as per current evidence and what guides these decisions in the absence of firm evidence?
Thank you. Most of the systematic reviews and the randomized controlled trials are providing the evidence that they are effective for about 6 months. Some have said 12 months, but that is a small number considering the radio frequency effectiveness for 6 months for other conditions such as facet joint pain. I think repeating after 6 months, if one obtains greater than 50% relief for 6 months, and that is based on the evidence. There are multiple systematic reviews on it. If you want, I will be happy to go over that.
Will you mean right now? You can summarize those?
Yes.
Or you're going to send them? Oh, okay. Go ahead.
There is a systematic review published in 2024 by Sotejo in Pain Physician. They performed meta-analysis of radiofrequency and pulsed radiofrequency and cooled radiofrequency. They identified about 11 publications with 604 patients. They showed that both cooled and pulsed RFA procedures targeting the genicular nerve resulted in considerable pain reductions at 3, 6, and 12 months. However, there was no significant improvement in physical and functional outcome for the cooled RFA technique in follow-up visits. There was significant improvement in physical function outcomes for the pulsed RFA technique at 1 month and 3-month follow-up visit. So overall, at 6-month follow-up, a total of 9 studies were included, with 5 studies of cooled RFA and 4 studies of pulsed RFA showing significant improvement from baseline. So 12 months was questionable, with only 4 studies meeting the criteria. Second systematic review and meta-analysis by Chen et al. It was published in Annals of Medicine and Surgery in 2023. They included 9 randomized controlled trials with 714 participants. In this evaluation, some studies utilized genicular nerve blocks, others performed RFA directly. The results showed that meta-analysis revealed that RFA demonstrated a significant short-term efficacy in reducing pain compared to the control group at 6 months, as indicated by the pain scores of reduction of 2.69. Similarly, Western Ontario and McMaster University's osteoarthritis index, or WOMAC scores, at 6 months favored the RFA group with a reduction of scores of 4.4. Based on this evidence, which is moderate, we believe that repeating them every 6 months would be appropriate, provided they do obtain 6 months of pain relief with improvement in their functional status. Thank you.
Thank you very much. I'm going to go back to the first question. If Dr. Schneider is not on, would one of you possibly be able to talk about the evidence regarding the efficacy of genicular RFA compared to genicular nerve blocks, placebo, sham, or other interventions? And are there societal guidelines to consider here?
This is Dr. Manchikandi again.
I can take
think
that question.
Okay, go ahead, please.
Yes.
Go ahead, Dr. Manchikandi.
Oh, okay. So as I described just now in reference to the systematic reviews, there is good evidence for, or moderate evidence, I won't say good, but moderate evidence for radiofrequency neurotomy. Cooled radiofrequency is difficult to perform in clinical settings because of the expense. It's more expensive, so it is not available in many settings, maybe in the hospital settings, but not outside. Now, there are not that many placebo-controlled studies, so it is hard to decide on the placebo-controlled trials. Now, radiofrequency neurotomy is definitely better than genicular nerve blocks. It has been compared, and the results are shown clearly. Other active interventions, there is one study where they compared the active intervention, like usual treatment, the radiofrequency was better. So overall, radiofrequency comes out to be better when they compare active controls with the conventional radiofrequency with cooled radiofrequency or pulsed radiofrequency. There is no difference. But if you look at the placebo or from the baseline to the monitoring level, the radiofrequency is superior to other modalities of treatments. So radiofrequency lasts 6 months, and genicular nerve blocks at best may last about 3 months.
Thank
So
you.
to add on to Dr. Manchikandi, there is one consensus guideline from the American Society of Pain and Neuroscience that has issued consensus for all RFAs for various pain conditions, and one of them is chronic knee pain. And that guideline supports the use of genicular RFA as an effective treatment option for chronic knee pain.
Thank you. Any other comments? I would presume that nobody would be doing any of this in an unstable knee for osteoarthritis. Is that one of the contraindications? If a knee is unstable?
Yes, that is
Okay.
in at least one of the studies that was listed as an exclusion criteria.
Thank you for that.
And
Are there
sorry,
any?
I was sorry, I was on mute before, but there is a multi-society guideline on genicular blocks and RFA in process, which will likely be submitted in the next few months here.
Okay, that's good to know. I had another question, whether anyone would proceed with radio frequency by some other choice than by seeing whether someone responded to a genicular block. Was there some other way that you might choose a patient or not? Because I did
Yes.
notice about the
This-
genicular blocks maybe not being so predictive. So that was my question.
Yeah, this is Ben Northrup. There are occasionally times where you would do it without a block, particularly if it was a patient who had responded very well to a prior genicular nerve RFA, and then, say a year or two down the line, they have recurrent pain. Then you might simply perform that again without doing a block in between. We do see this particularly in knee arthroplasty patients who have chronic pain due to synovitis, for example. And they've responded well before, then there's no need to do another block when you're doing essentially a repeat later on.
The study, this is Dr. Manchikandi again, the study performed by Snyder, I think, or Snyder, it showed that there was no difference. Predictability was not certain. And there are systematic in the randomized controlled trials where they have performed the RFA without a diagnostic block. I was reviewing an article, they were questioning that, well, they don't do any diagnostic blocks before they do a total knee. Why do you have to do a diagnostic block before you do radiofrequency neurotomy?
Are you suggesting we would have logic in medicine, Dr. Manchikani?
No, I'm not suggesting at all. I'm in favor of actually doing the diagnostic blocks. I'm against not doing the diagnostic blocks, but I'm just saying that there are studies doing radio frequency directly without diagnostic blocks.
Yes, I know. I saw some of them, which is why I was asking you guys the question of what you thought about that. But thanks very much. I think my section is out of time, and I want to thank you all for participating in this, and I'm going to pass it off. Mark, I think it's you next, but I've lost my notes. Is it Dr. Durden?
Yes.
It is.
Thank you. Thank you, Eileen. So this first question is to Dr. Vorenkamp. I'd like to discuss intercostal nerve blocks. Is there any robust evidence supporting the use of perioperative analgesia in thoracic surgery, such as the video-assisted thoracoscopic surgery or the thoracotomies, compared to other regional anesthetic techniques?
And I'll ask my other colleagues to add in. Intercostal nerve blocks today are less commonly used in the world of ultrasound, and the thoracic fascial plane blocks and epidural catheters are still for the mainstay for open thoracotomies. But intercostal nerve blocks, there is supportive evidence. It's not superior evidence to an epidural, a thoracic paravertebral block, the thoracic fascial plane blocks, but there may be reasons why you would do it, either because of local contraindications in that area where you may need to do a more anterior lateral approach. So there is some supportive evidence, but it would not be superior to the other blocks listed, like epidural, perivertebral, or recti spini in the perioperative population.
Excellent, thank you. Dr. Batista, does the current literature support intercostal nerve blocks in reducing postoperative opiate consumption and things like improving patient-centered outcomes, such as their recovery and their satisfaction?
So, Dr. Vork said, like, there are a lot more options in intercostal nerve block for perioperative use. However, it still showed a decrease in opiate consumption and patient satisfaction, but not superior to thoracic epidural, perivertebral blocks, or erector spiny blocks. But if the question, if it does it decrease opiate consumption, the answer is yes.
Okay. And for what period of time do they measure that reduction in opiate consumption?
For all the studies, is like short term for the duration of admission, usually for within a week.
Okay. Back to Dr. Vornkamp. Dr. Vornkamp, could you discuss the limitations and potential risks associated with an intercostal nerve block for postoperative analgesia? And does the evidence address any of these concerns?
So the biggest risks in terms of performance, certainly we're in close proximity to the pleura. So risk of pneumothorax, risk of intravascular injection, like anything, risk of bleeding and in infection as well. These would typically be done in the setting of thoracic surgery. Does the evidence adequately address these concerns? I think so. I mean, all of these are kind of risk benefit. When we place a thoracic epidural, we're millimeters from the spinal cord. When we do an intercostal nerve block, we're millimeters from the pleura. So it's always risk benefit. So yeah, like I said, in terms of widespread adoption, that's not where we are currently, and that's not the direction the field of regional anesthesia is going to with intercostal nerve blocks. Their role is really for a rare or unusual situation, typically for patients with thoracic surgery. Now, when we're talking about intercostal blocks in RFA for chronic pain, that's a different field, but I know this is focusing on postoperative analgesia.
Thank you, too. I appreciate your input. I'm going to shift gears a little bit and like to now talk about ganglion impar blocks for coccydynia. And this is to the group. Is there enough high quality evidence or robust evidence to support a ganglion impar block as an effective treatment for chronic coccydynia, particularly in patients not responding to conservative management?
It's very hard to study ganglion impar block because number one, a lot of insurance companies will not approve it. So it's very hard, but I think there is utility for that.
But looking at the evidence of what's been out there, so you have Swain, Sangar, Nasiri, you have a number of small studies that are out there. Of those studies, is there enough evidence to support the use of these impar blocks for the treatment of chronic coccydynia, and broadening the question just to make sure I was clear that and would you do the impar block, particularly in patients that are not responding to conservative management, and what would that conservative management really entail?
In terms of indications, it would be chronic pain that hasn't responded to conservative measures, which typically is going to be your medications, often using the different cushions, different ways of offloading that area, maybe some physical therapy, although the whether that's pelvic floor physical therapy or kind of more back directed. So yeah, this would be for patients that have failed conservative studies or conservative measures. And I think there is a role for this, whether it's a ganglion impart block or a coccygeal trigger kind of local injection there. But there are limited studies. It's a pretty limited volume of patients that we're looking for. Typically, yeah, for chronic coccydynia or chronic pelvic pain.
Thank you. That has been my experience as well as I've been reviewing the literature. Does anybody else like to add anything else before I turn the time over to Dr. Volker?
This is Dr. Manchikanti again.
Sure, tell me.
The evidence is limited, but condition is significant. People may have significant pain, and impart block is performed for other painful conditions in the perineum and pelvis. There is only one randomized trial, I think, that is, so evidence is very limited. And it is very uncommon to procedure to be performed. So it is. So if it is not a very common procedure, does it even require an LCD? That would be another considerations.
Yes, thank you. Okay, this concludes my section of the CAC, and I'll now turn the time over to Dr. Volker.
Thank you, Dr. Dwarden. All right, Dr. Bautista, what does the evidence suggest about using pudendal nerve blocks for reducing post-operative pain in adult patients undergoing perineal surgeries compared to standard anesthesia? Usually, my familiarity is use for that in urogynecologic surgeries.
So there's quite a bit of like systematic reviews that look into the utility of pudendal nerve block in hemorrhoidectomy, and those reviews have shown like significant improvement of their pain. There is for gynecology, and again, there's also very limited like randomized controlled trial, but all those trials have shown evidence that it decreases post-operative pain for patients undergoing gynecologic surgery. But overall, I think it's a good option if decrease opioid consumption and if exhausted all analgesic regimen.
Thank you. If I could expand that just a smidge, and do you have any evidences using pudendal nerve blocks for chronic pelvic pain, particularly dyspareunia? Do you know of any evidence for that? I know a lot of people use it, but I didn't know if you were aware of any evidence that would support or refute that.
So the strength for pain control for chronic pain, again, it's very limited. There are like small studies that looked at randomized control trial, and it definitely showed reduced pain scores for a brief time period. Actually, currently we are our group and the gynecologic group, Urogyne group, are doing a study to see the efficacy of peripheral nerve pudendal nerve block using ultrasound and fluoroscopy and longevity of the pain relief. So again, the it has been a lot of people are doing that for chronic pain, and there are some limited studies that show that it is beneficial.
Thank you very much. And now I'm going to switch subjects a little bit. And Dr. Mangiaconti, is there compelling evidence supporting the use of cryoneurolysis over radiofrequency ablation for chronic pain conditions such as facet joint pain?
There is not compelling evidence. The evidence is not even equivalent, leave alone superior, and there is no evidence showing that it is not inferior, or there is evidence showing that cryoneurolysis is inferior to radiofrequency neurotomy in almost all conditions. Cryoneurolysis may be preferable. There is no evidence again. So preferable in knee neurolysis procedures. So the answer is the evidence is not superior and not equivalent to radiofrequency ablation in chronic painful conditions. It may have a selective use specifically for knee pain. Its use for facet joint pain is laborious with suboptimal results.
All right, thank you very much. And we will move now to nerve entrapment and peripheral nerve blocks. So Dr. Nelson, what does the literature say about using peripheral nerve blocks versus conservative therapies for nerve entrapment syndromes, such as anterior cutaneous nerve entrapment or lateral femoral cutaneous nerve entrapment, which I believe is known as meralgia paresthetica?
Our section is the lower extremity, like below the knee. So this area wouldn't be my area. Ours is a little further down for the peripheral nerves.
Okay. Does anybody else have anything to opine on that?
I would, yeah, certainly for the meralgia paresthetica, you were attempting this after conservative measures have failed, and these have been treatments that have been kind of the mainstay for those patients that have failed conservative therapy for several decades. And as our imaging techniques with ultrasound have become prevalent over the last 10, 20 years, I would say our success of treating these nerves, like the lateral femoral cutaneous, is much higher. Most of the literature is limited to case series. I'm not aware of any placebo-controlled, but yeah, many of those do show very positive outcomes in case reports.
Thank you. And then the final question would be to Dr. Barrett and Dr. Nelson, if you could provide any insights into the role of peripheral nerve blocks in managing conditions of the lower extremity based on current evidence.
Yeah, this is Stephen Barrett. There's not a lot in the literature as far as the efficacy of lower extremity peripheral nerve blocks. However, there are 3 studies that are listed on this outline. They have very good potential for aiding in the diagnosis of certain specific nerve entrapments, such as common perineal nerve at the fibular neck and tarsal tunnel. The one study from Iborra et al. Actually compared it to EMG findings and found that it was able to pick up nerve entrapments much earlier than with traditional electrophysiological diagnostic methods. It's also being very significantly implemented in mapping out different nerve involvement with different traumatic areas, such as like if there's an injury on the dorsal aspect of the foot, which nerve is it? Is it superficial perineal or deep perineal, or is it even a saphenous? And by using lidocaine, you can do mapping, but there is not a lot of literature, quite frankly, for this.
Okay. Anybody else have anything? Otherwise, I will yield my time to Dr. Lovelace. So thank you all for your insights. And Dr. Lovelace, I will now pass the baton to you for section 3, which is head, neck, and upper extremity.
Thank you so much. And so we'll move forward with carpal tunnel syndrome. And Dr. Azad, we'll start with you. Is there evidence supporting the use of blocks or steroids for managing acute pain in carpal tunnel syndrome?
You know, as I told you, I'm as president, I'm far away from US, and I forgot to assemble some of this review. So if somebody else want to help out on this question, I'm in India at this time, and it's middle of the night, and I have misplaced all the paperwork. So if somebody can help us out, that'll be great. Thank you.
Any volunteers to take this question? The question is do blocks or steroids, are they useful in managing acute pain in carpal tunnel syndrome? We're referring to steroid injections.
This is Dr. Buznowska. I can make a comment about this question.
Yes,
please. And in general, studies looking at carpal tunnel syndrome look at chronic carpal tunnel related pain or median nerve compression pain, not acute. So if this question is specifically referring to acute pain less than 6 weeks, then there is no evidence that looks at that. But when it comes to chronic pain, and I guess that's your next question, so I'm going to leave that to the next person.
Well, that one's geared towards the group because we didn't. So if you want to comment further on the chronic, that would be wonderful. Or if anyone else wants to contribute to the use of injections for chronic carpal tunnel syndrome.
So several studies have looked into corticosteroid injections, and it provides transient relief of symptoms. No long-term evidence of longevity of pain relief. However, patients who would qualify for steroid injection should have failed conservative management that includes and physical therapy as part of their non-invasive treatment.
And if they respond, would those injections be repetitive management, or would that be something done as a diagnostic before going on to a surgical treatment? If anyone wants to elaborate just for our understanding.
So that is my question.
So the thing with chronic steroid injection.
So question number 3 is about frequency of repetition of steroid injections for carpal tunnel syndrome. So there is no study that looks at that specifically. How frequently should their steroid injection be repeated for carpal tunnel before a surgical approach is considered? And the way that carpal tunnel syndrome is addressed in the literature is evaluated based on the severity of symptoms as reported on an EMG study. So if the carpal tunnel syndrome seems to be mild or moderate and conservative management is exhausted, then steroid injection does seem to provide excellent relief for between 1 and 12 months. So different studies look at different, report different results, and that seems to be dependent on the predisposing factors and causes of carpal tunnel. So patients who have underlying diabetes tend to have shorter duration of relief and more recurrent symptoms. patients who have other sources of carpal tunnel syndrome may be related to occupational repetitive stress that can be maybe addressed in some ways. Those patients tend to report symptoms or have relief from those of the symptoms for much longer, and can be up to even 12 months. But most studies look at outcomes at 4 or 12 weeks or 24 weeks. But there is no study that look at exactly how many times you have to repeat steroid injections before you give up.
Thank you for your answer. I appreciate that. And from the radiological perspective, Dr. Northrup, what is your thought? What does the evidence say about if ultrasound guidance is necessary to perform these injections for carpal tunnel?
Yes, thank you. This is definitely an excellent question, and one for which the evidence and current clinical practice is a little bit incongruent. So first off, thank you for including those 8 references in the packet. Reviewing those, there are 4 of those 8 studies in which all injections used ultrasound guidance. There were 2 in which it was not mentioned, so we have to assume that it was either intermittently used or not used. There was a systemic review from Dong et al. In which most of the studies used ultrasound guidance, and then a final one, Karamet, which compared ultrasound guided versus blind steroid injections. So let's start with that one because that's the most direct comparison. So that one compared the effectiveness and the safety of each approach. It did find that both groups did show improvement in both the Boston Symptom Severity Scale as well as the Functional Status Scale. However, the ultrasound group saw significantly greater relief, and that relief came a bit earlier. Another study not included in the packet from 2013, Houston, and I can send you the link for that or the reference for that if you'd like. So that compared anatomic-based blind injections to ultrasonography, and they showed that the ultrasonography guided injections were more accurate, more effective, and had less iatrogenic injuries. Both groups did demonstrate improvement, but once again, the ultrasound guided group showed an earlier onset of relief, and they showed more improvement or a greater improvement in terms of symptom severity scores. So that's efficacy. Let's go on to safety here. So ultrasound is going to allow for more accurate assessment of the safe zone for intervention, and the anatomic area that is relatively devoid of major neurovascular structures can be better evaluated. Very important not only for the ones you think of, like the superficial palmar arch, ulnar nerve, ulnar artery, etc., but some patients, a small but significant number, have a persistent median artery, and you certainly don't want to inject that. So ultrasound, and there's a few studies that showed that, just simply the effectiveness of ultrasound in identifying those structures and avoiding them, and I can send you the citations for those if you would like. So then there's another study that was not just looking at can you see them and can you avoid them, but the actual outcomes. And that one showed, this is also from the Houston study from 2013, another portion of that study, that did show that there was indeed less iatrogenic injuries, so better outcomes from a safety standpoint, in addition to the prior study, which showed you can see it better and avoid it. And then the final thing to talk about here, just in the interest of full disclosure here, as I said, there is some incongruence between the evidence and clinical practice. Medicare databases do show that only about 14% of the time are these performed with ultrasound guidance. 86% of the time they are performed blind. And let me know if you have any further radiology-related questions.
And we would greatly appreciate you sharing the evidence that you've mentioned with us, and as well as for all of our speakers who have mentioned literature or evidence that was not included in the in our bibliography list. We would greatly appreciate if you can share that with us, as well as any additional comments that you have on the questions after our meeting. And I'm going to move forward into our neurological world with a question for Dr. Pakat. Is there supporting evidence for the use of blocks as a diagnostic tool for occipital neuralgia?
Hi, yes, this is Dr. Brian Paquette. So I'll take this one. Is there evidence to support blocks as a mechanism to diagnose occipital neuralgia? And the answer is yes, in conjunction with a thorough history and physical examination. And there is good evidence, and in fact, the American Academy of Neurology has guidelines in support of this. Initial treatment should focus on conservative measures, of course, like medication, including anti-inflammatory drugs, muscle relaxants, sometimes anticonvulsants. Although I'd say as a interventional headache specialist, I actually believe that employing a block earlier in the sequence is probably safer and more effective, but that's my opinion, and so I'm relegated to what the American Academy of Neurology guidelines tell me to report here, which is that we will use them for refractory cases, but ultimately these occipital nerve blocks can be used as a diagnostic and therapeutic tool.
Thank you so much. And to follow up with that, Dr. Batista, does the current evidence support the use of block applications to relieve occipital neuralgia pain compared to standard of care, and any guidelines on frequency?
So there are studies that shows like there are block relief for individual occipital neuralgia. Use of like dexamethasone in patients with other cranial pain syndrome have found to have reduced pain after, again, a steroid injection. In the study, a meta-analysis study by Evans et al. In 2023, they tried to investigate a change in headache severity and frequency following those nerve blocks. And those are like 12 randomized controlled trials with a total number of almost 600 patients, and found that may be beneficial in severity and frequency of occipital scalp pain or tenderness. As to the optimal number and frequency of nerve blocks for effective pain relief in occipital neuralgia, it's not very well established due to the limited high-quality evidence. However, in clinical practice, we often tailor the frequency of these on individual responses, the duration of relief, and usually, typically in every 3 months or so. The event lasted less than 2 months, so the clinician should consider other headache medications or other interventions.
Thank you so much for your answer. And we're going to now focus on stellate ganglion blocks, and this question is for the group. Is there any evidence to support the use of stellate ganglion blocks for hot flashes as compared to standard therapies? And if so, any recommendations on frequency? And if there's no volunteers, I'll move forward with the next question, and we'll we have very limited papers on this, as you can see in the bibliography, but we just wanted to seek if there was any additional input. So we'll refer to the papers there, and if anyone has any additional to contribute, please send our way. So the next question is for Dr. Paquette. Is there evidence supporting the effectiveness of stellate ganglion blocks for spasticity? And does it include any guidance on frequency?
Yeah, there's a paucity of evidence on this particular topic, and this is outside of my specific area of expertise, so I'll welcome my PM&R colleagues to chime in if they have further information. There is a study by Yan et al. Discussing the clinical efficacy of ultrasound-guided stellate block combined with extracorporeal shockwave therapy on limb spasticity in patients with ischemic stroke. And they looked at 60 patients diagnosed with ischemic stroke by limb spasticity. And this study was done in China, where they administered 3 to 4 milliliters of lidocaine as their block, and they did this every 3 days for a month. And their conclusion was that, yes, there is evidence to support the use of stellate ganglion blocks for spasticity compared to standard of care. Ultimately, they looked at those who were receiving the combination of stellate ganglion block plus the extracorporeal shockwave therapy as the more superior group. Obviously, also, this would be done after standard of care for limb spasticity is performed, such as oral muscle relaxants, Botox injections, physical therapy, occupational therapy, even considering also intrathecal baclofen therapy may be a nice option if there was more reliable data, as stellate ganglion blocks in the right hands are a safe procedure. But otherwise, this study really, there weren't too many other studies that looked at this. But despite those limitations, the limitations of this single study, this could be a potential option.
Thank you. Thank you for your answer. Dr. Pollock-Tunis, what does the evidence suggest regarding stellate ganglion blocks for PTSD? And again, any recommendations for number and frequency?
Sure. So again, not a whole lot of evidence here too, but the Canadian Journal of Health Technologies actually published a review article in March 2021, and they were summarizing findings from studies coming from one systematic review, notifying that the stellate ganglion block for treatment of PTSD versus sham did not provide clinically significant improvement in comparison to sham. And they also noted, and the other study, which was a primary randomized controlled trial, which you guys listed here, is the Ray Olmsted study. This one actually was comparing the effects of 2 rounds of stellate ganglion blocks versus sham, and this did show improvement of a CAPS-5 total symptom severity score at 8 weeks. But those were the 2 that were that I was able to find. Again, based on the systematic review, there did not provide significant benefit, but then the randomized control trial did show some improvements.
Thank you very much. Appreciate your looking into that. And our next question is for Ann Mosconi and Mary Walsh-Sterup, and we're inquiring about evidence for stellate ganglion blocks for complex regional pain syndrome in adults as compared to standard of care. And again, if any evidence about frequency.
Thank you. This is Ann Mosconi. I'm happy to answer that. The standard of care for persons with CRPS is outlined by Harden et al. In the 5th edition of the CRPS Practical Diagnostic and Treatment Guidelines, which was published in 2022 on behalf of the American Academy of Pain Medicine. And these guidelines advocate for a multidisciplinary approach, emphasizing the importance of specific evidence-based interventions in occupational therapy and physical therapy with a primary focus on functional restoration. It does support the use of medications, including sympathetic nerve blocks, but only when the patient is unable to initiate or progress in therapy. And in those cases, a short course of stellate ganglion blocks should be considered only in combination with OT and PT interventions per this manual. With regard to the question, is there evidence to support number and frequency of block applications to effectively relieve pain? I couldn't find anything specifically in the literature that definitively answered this query. Overall, the studies were limited by small sample size and large amounts of variability between the studies, making it really hard to generalize any findings for a broader population. But in general, the articles that we have do suggest that it is that stellate ganglion blocks can assist in situations in which the patient is having trouble participating in occupational and physical therapy.
Thank you very much, and for the reference as well. And Dr. Paquette, what evidence exists regarding stellate ganglion blocks for Bell's palsy and any guidance on how they should be applied?
Yeah, so Bell's palsy, it can be a difficult condition to treat. Current treatment strategies are not very effective, typically heals with time, but for some people it can be a chronic, disfiguring, debilitating condition with ophthalmologic impact as well. Stellate ganglion block is a sympathetic nerve block, while it's commonly used for conditions like CRPS and vascular insufficiency, certain other types of face pain and other pain syndromes. Its use in Bell's palsy is really less well established. However, the rationale may be enhanced microcirculation of the facial nerve and reduction in edema and inflammation, and ultimately leading to improved nerve healing. So what we do have is some limited case reports. We do lack large scale studies. However, there is one randomized trial by Liu et al., who in his small randomized single-blinded clinical trial involving 96 diabetic patients with Bell's palsy, randomly divided into control and treatment with equal severity of the Bell's palsy prior to treatment, there was a significant improvement in their functional disability scores between the two groups. The safety, they commented, was they had good safety data regarding this, and I think that holds true with other conditions that respond to stellate ganglion block. One interesting study that was not in this section but may be applicable is Kawabata et al. Described prolonged blockade of the cervical sympathetic nerve by stellate ganglion block, accelerating therapeutic efficacy in trigeminal neuropathy. And the purpose of that study was to investigate the relationship between the blockade of the stellate ganglion and improvement in trigeminal neuropathy after orthognathic surgery. The study aimed to determine if this blockade would help in that recovery, and what they found was that there is therapeutic efficacy, and I thought maybe this was also applicable to the healing of the facial nerve in Bell's palsy, but otherwise small and paucity of data overall for the use in Bell's palsy.
Thank you so much.
That's it.
Dr. Manchakanti, can you explain to us the evidence to support the use of stellate ganglion blocks for post-herpetic neuralgia, and also any recommendations on number and frequency?
There are no society guidelines. There are few studies and multiple systematic reviews evaluating the role of stellate ganglion block in post-herpetic neuralgia. However, the systematic reviews included multiple treatments. These systematic reviews included 1 or 2 studies in the entire picture, so they're not very useful here. Of importance is that a randomized control trial was published by Makarita in Pain Physician in 2012. This randomized trial evaluated the effect of early stellate ganglion block for facial pain from acute herpes zoster and incidence of post-herpetic neuralgia. They included 64 patients to receive either a stellate ganglion block using 8 ml of sodium chloride solution or 6 ml of bupivacaine with 8 milligrams of dexamethasone in a total volume of 8 ml. All procedures were performed under fluoroscopy. All patients received pregabalin in a dose of 150 milligrams twice daily, along with Tylenol. Pain assessment was performed using VAS up to 6 months. Group 2 receiving bupivacaine and dexamethasone showed significant reduction in pain and satisfaction at 3 and 6 months. By the 4th week, 29 patients in Group 2 reported no pain at 3 months compared to 22 patients in the sodium chloride group. Further, mild pain was reported in 2 patients at 3 months, with none of them reporting moderate or severe pain, whereas 8 patients reported moderate pain in placebo group. So this is a reasonably well-conducted placebo-controlled trial with significant improvement in the treatment group. However, significant improvement was also seen in the placebo group, even though less than treatment group. The question here comes is, if sodium chloride solution into the stellate ganglion block was truly a placebo. There are multiple studies in epidural injections and facet joint injections showing the effectiveness of sodium chloride solution as a therapy. Thus, injection of sodium chloride solution, which is an inactive solution but into an active structure, may provide false positive results. A true placebo would have been injecting the sodium chloride solution outside the stellate ganglion block, stellate ganglion into subcutaneous tissues. There is another study published adding extracorporeal shockwave therapy, ultrasound guided stellate ganglion block. In this, they studied 36 patients into 3 groups, very small number. So they basically showed that stellate ganglion block with shockwave therapy works the best, but they repeated this every week for 6 weeks. I don't see much of clinical use with this study. They also compared another study, Fan et al. Compared lidocaine and ropivacaine in treating post-herpetic neuralgia in 252 patients, and they did not see any difference between both. It is an active control trial. Active control trial. So overall, there is level 3 evidence with 1 randomized placebo-controlled trial and 1 retrospective comparative study of ropivacaine and lidocaine. I would say with moderate recommendation. In reference to the frequency, these can be performed frequently for 3 times with at least 2 to 4 weeks, 4-week intervals, preferably 4-week intervals. Then if they respond to that and the pain returns, they may be performed once in 3 months, provided they show 3 months of improvement in pain relief as well as functional status. Thank you.
Thank you. And the final question in this section is for Dr. Vorenkamp. And is there evidence supporting the use of stellate ganglion blocks for relieving acute postoperative pain? And would there be any indication to repeat that?
And I don't have much to add beyond the article that's included, which I think is the final reference 16. But yeah, they have a meta-analysis of 7 small studies showing improvement in pain compared to either a placebo or to no intervention at 8 and 24 hours. A couple of the studies tracked it out to 48 hours. I am not aware of any literature showing repeat injection either subsequent to that time. So yeah, my impression is that this has limited evidence for use in the acute postoperative period. And I'm not familiar with any literature showing repeat of the stellate block.
Thank you very much. And the next section addresses trigeminal neuralgia. And for each of these questions, if you can comment on the number and frequency of applications. The first is for Dr. Paquette. For trigeminal neuralgia, is there evidence supporting peripheral nerve blocks for short-term use?
Yes, so trigeminal neuralgia, it's a rare condition like many of these conditions we're talking about. And so the number of patients required to adequately power a randomized controlled trial makes this particularly difficult, but there is some data to support its use. L-Shake, Moore, and DiStefani are the studies that I looked at. Moore et al. Demonstrated in their study a systematic review for rescue analgesic strategies in acute exacerbations of primary trigeminal neuralgia 2019. And they used PRISMA, preferred reporting items, for systematic reviews and meta-analysis as their flow diagram to report on 17 studies offered analgesic therapy within 24 hours of administration for trigeminal neuralgia. And ultimately, the evidence supports the use of blocks in acute trigeminal neuralgia, but they suggest further studies are warranted. Whereas L-Shake et al. In their study, local anesthetic and steroid injection using a modified coronoid approach in trigeminal neuralgia 2016, yes, there is evidence to support the use of peripheral nerve blocks. The study evaluated the effect of adding calcitonin to the local anesthetic. It's not something that I use in my practice. But in this study, they showed that the addition of calcitonin significantly prolonged the duration of effective pain relief compared to the control group. Specifically, the duration of effective pain relief was significantly longer, 34 weeks as compared to the control group of 16 weeks. Fewer patients in the calcitonin group required repeated blocks, and there were no serious adverse events. And so when we talk about number and frequency of blocks, there's no specific guidance on this. However, in this particular study, every 16 to 34 weeks seems the duration that they were going for. And D. Stefani, their study on the combination of pharmacotherapy and lidocaine analgesic block of the peripheral trigeminal branches for trigeminal neuralgia 2015, their primary objective was to evaluate the therapeutic effect of combining pharmacotherapy with lidocaine analgesic block, which is more common in our practice, is to combine therapies on the peripheral trigeminal branches. So specifically, the study aimed to assess the reduction in frequency of pain episodes in a month, measured at 30 and 90 days after the treatment. And what they found, 13 patients with classic trigeminal neuralgia were involved in the study. So it was a small study. The patients were divided into two groups. 7 patients received only pharmacologic treatment, and the second group, 6 patients, received pharmacologic treatment in addition to lidocaine analgesic block. Lidocaine injected was administered to the area of most intense pain, and the pharmacologic treatment included the typical medicines carbamazepine, oxcarbazepine, as well as gabapentin and lamotrigine. The authors concluded that the combination of pharmacologic therapy and lidocaine analgesic block of the peripheral branches resulted in a significantly lesser frequency of pain, and additionally, the combination led to a consistent reduction in pain and improvement in quality of life over their observation period of 90 days. And so the study suggests that this combination therapy is beneficial overall. Small sample size, of course, it's a rare disorder, difficult to study, but there are some reasonably good studies to support its use for acute trigeminal neuropathic pain.
Well, thank you for that thorough answer. That's very helpful. And for Dr. Batista, how about the use of peripheral nerve blocks diagnostically for trigeminal neuralgia?
Based on the studies, that it can assist in diagnosing trigeminal neuralgia by temporarily alleviating the pain. So it therefore kind of helps confirm the involvement of specific nerve branches. Like, for instance, like blocking the peripheral branch of the trigeminal nerve can help identify the affected division responsible for the pain. And also, this can aid in distinguishing trigeminal neuralgia from other facial pain syndrome. However, beyond the diagnosis, the utility of nerve block for trigeminal neuralgia showed like very limited studies. Again, as what the former expert have said, it's very difficult to study. So there's very limited data. But doing those nerve blocks have reported significant reduction of pain severity and frequency over a period of 6 months period for some studies.
Thank you so much. And we're heading back to Dr. Paquette to discuss refractory trigeminal nerve cases and if peripheral nerve blocks have a role in that scenario.
Yes, peripheral nerve blocks have a role in this scenario. As trigeminal nerve patients, as many of us, we treat these people. These are people that are highly debilitated. This is a terrible condition. We don't have many tools to help them. Once they become refractory, these nerve blocks are, in my view, critical. Unfortunately, there is limited high-quality scientific studies for the reasons I mentioned earlier. In the publications that are available to me through the American Academy of Neurology, June 2021, there is recommendation in Continuum Lifelong Learning in Neurology to provide trigeminal nerve block, and not only for an acute exacerbation, but also potentially on a scheduled basis for preventive therapy. A systematic review published in Pain Medicine 2021 found that local anesthetic blocks provide immediate relief, and although long-term efficacy remains uncertain, for repeated blocks is recommended. So this question, is it refractory trigeminal neuralgia? Is there evidence to employ periodic nerve blocks for the treatment of refractory trigeminal nerve blocks? Is this acute flare-ups? Or are we employing this as a scheduled maintenance therapy? So these are, in my view, two different scenarios, but in both scenarios, patients respond favorably to these peripheral nerve blocks. and several blocks may be necessary to achieve adequate pain control and improve central and peripheral sensitization. Moore et al. In their review, treatment was deemed effective if it resulted in better than 50% overall pain reduction in 24 hours after administration. And they used the VAS scale, NRS, and verbal pain rating scale in their review. Overall, the quality of evidence is low. The sample sizes are small. The study designs don't include many randomized controlled trials, again, for the reasons that I mentioned. However, the use of these blocks is highly effective. So the current recommendation is to include these blocks in conjunction with traditional pharmacologic therapy for the overall treatment of this patient population.
Thank you so much. And we are on our final section of our meeting today. And this is on radio frequency for trigeminal neuralgia. And this question is directed to the group. Is there evidence to support radio frequency ablation for decreasing pain for patients with trigeminal neuralgia?
I'm happy to go first. Yeah, this was actually the first application of radiofrequency ablation for chronic pain. And so I believe it was 1967 when the original article came out. So yeah, there's many decades of supportive evidence in a subset of patients. Certainly those that are more elderly with comorbidities, for those that don't have the indications for microvascular decompression or have failed it. So as a palliative treatment, there is decades of supportive evidence.
Thank you so much for that answer. And Dr. Paquette, how about does radiofrequency ablation help reduce the need for surgery in these patients with trigeminal neuralgia?
Yeah, I think really this is a follow-on question to what we just talked about. Radiofrequency ablation can be very effective. The data are pretty clear that if someone has a compressive lesion identified causing the patient's trigeminal neuralgia, that microvascular decompression is likely the treatment of choice. That's barring if the patient has any reservations or contraindications. In short of that, if there is no definite compressive lesion discovered, then microvascular decompression is really not an option. And the evidence is clear that radiofrequency ablation, a minimally invasive procedure, can be very effective.
Thank you very much.
I have plenty of literature to share with you on this. I can do that
yes, please
later
do.
date.
Our final question, which was for the panel, how frequently would the radiofrequency ablation be performed in these cases? Do we expect pain relief for 6 months like in other areas that we've discussed, or is there some variation in this area?
I think that's a similar, reasonable expectation. There are some situations, certainly trigeminal neuralgia in some subsets, a particular MS, may be more refractory. So you may need to use more aggressive lesioning parameters. So you may start with a more standard MS protocol. And if you don't get significant relief, you may modify your treatment modalities. But in general, I think 6 months is kind of the target where we would want to repeat it, but there may be some exceptions in certain patient subsets.
Thank you. And in follow-up to some of your responses for this head, neck, and upper extremity section, at one point, Dr. Paquette, you mentioned that the stellate ganglion block is safe in the right hands. What does the panelists consider the appropriate training for these head and neck or requirements for training for these procedures? And my additional question is really geared towards Dr. Northrup. Is there any recommendations regarding image guidance for these head, neck, and upper extremity procedures?
Yeah, I can go first concerning imaging guidance. I do not have it in front of me, but there are several papers I can look up later and provide references concerning imaging guidance. There are even a few that use fluoroscopy, but I would say the majority of people, particularly for the head and neck interventions, are going to use CT guidance for it. Some of the other upper extremity ones, in some cases, fluoro could work for certain nerve blocks. Ultrasound is probably most common. There's evidence for all of these. It would be a very long reference list, but yes, as a general statement, most of these will use imaging guidance of some type, and some of the more dangerous ones, particularly those in the head and neck, you'll definitely need CT.
In terms of basic training requirements, I'm not aware of any reference of anything we've looked at today that of any procedure performed by non-physicians. So everything we've discussed are procedures in literature performed by physicians. The majority of these are provided by anesthesiologists, physiatrists, neurologists, radiologists, neurosurgeons, orthopedic surgeons that typically have a minimum of 4 years of post medical school training. But I am not aware of any performed by non-physicians.
Thank you so much. And that concludes our questions section. I just want to thank everyone for your insightful and valuable contributions to this discussion. And I'm going to turn things back over to our moderators.
Yeah, so that ends our question section. I'll leave a few minutes from any of our panel if there's any sort of final comments or anything to add from anyone. And
yeah, I do have a quick question here. This is Ben Northrup. So I noticed at the end of your document, you had a final question that we didn't get to here. It said, are there additional peripheral nerve blocks that we did not include in the discussion? And certainly kind of a loaded question, because you can always find something minor. But I just did want to point out, and some of these might be included in some of the general categories, such as upper extremity, pelvic lower extremity, etc. But just as a point of reference, ones that were not specifically mentioned but have met the very high criteria for Category 1 CPT codes include vagus, brachial plexus, suprascapular, axillary, paracervical or uterine, sciatic, ilioinguinal, iliohypogastric, femoral, and digital nerve blocks. So all of those do have Category 1 CPT codes, needed the evidence and widespread utilization to achieve that Category 1 CPT code, that is, and those were not mentioned. So just wanted to point those out. I can include those in an email if you want the full list.
Yeah, I think that would be helpful, just to make sure that we have everything that we talked about. An email would be helpful. And thank you for bringing that up. Is there? I'll leave it open for another minute. Anybody else with another comment or concern? Hearing nothing there, I believe that concludes our Contractor Advisory Committee meeting. On behalf of the contractors, I would like to thank everyone for their participation and very constructive comments. Your involvement is an invaluable part of our process, and we greatly appreciate you sharing your knowledge and expertise. The information that was shared today will be carefully considered as we move forward. Just to reiterate, if there are references mentioned that are not included in our references list, please send them so we are all thinking about and talking about the same literature. And to conclude, thank you again, and everyone have an excellent afternoon.